Hello class, we're going to get into this pre-recorded lecture. Will be the first lecture of two when we're going to be talking about the ears, the eyes, nose, and throat, and the disorders that plague many people. And the first one that it always comes up in Chinese texts is tinnitus. And tinnitus is actually a minor disorder, but it could be a red flag for a multitude of situations and disorders. So we're going to go through those, and I think that's very important about this lecture. Is there's like 12 or 13 slides I think involving tinnitus, and the reason being is because of the seriousness. If it became something else, um, it could be secondary to a lot of major things going on within the skull and in and around the ears, to include tumors and bruits and things like that we can hear. We could actually stick the stethoscope right on the ear and on the skull and hear things. And we're not used to doing that, but it's possible. And there's actually diagnosis tests in finding things within the skull using a stethoscope. So I think it's an exciting area, and we'll go ahead and get started on it. These are the subjects we're going to be talking about: is tinnitus and deafness, tinnitus, dizziness and vertigo, acoustic neuroma, benign paroxysmal positional vertigo. And you never have a want to have vertigo. It's pretty, it's not painful, it's just really bothersome. It could be painful for some people. And then we're going to talk about Meniere's disease, and then labyrinthitis. We're going to get into some vestibular neuronitis, middle ear and tympanic membrane disorders, mastoiditis, otitis media, the acute stage, and of course the traumatic perforation of the tympanic membrane. That's your Q-tip injury, and we want to avoid that at all costs. These, a lot of children show up to the ERs with stuff stuck in their ears. People like to put things in their ears. So we're going to talk about that a little bit. Okay, so tinnitus is any noise that is generated by the ears themselves, and it can be subjective tinnitus, which is the most common form of tinnitus, and it's the perception of sound in the absence of an acoustic stimulus, and is heard only by the patient, and they can only explain it to you. And then there's objective tinnitus. It results from noise generated by structures near or in the ear. And this is much less common, sometimes loud enough for the examiner to also hear it. And it is important to distinguish the etiology, because I think I've mentioned before that tinnitus could be a very serious condition. Depends on what's going on inside. But you always want to have an eye out for this and be aware that it could be something very serious inside. And we're going to talk about a lot of those disorders. So tinnitus noise is described as buzzing, ringing, roaring, whistling, or hissing, and is sometimes variable. Most noticeable in quiet environments, in the absence of distracting stimuli, and it seems to be worse when going to bed. It could be a bad pillow, just pressing up against a vessel, and your senses pick up on that, and it could be very distracting stimuli, and again it might be intermittent or continuous. So subjective is thought to be caused by abnormal neuronal activity in the auditory cortex of the brain due to disruption or alteration of input from the auditory pathway, and loss of suppression of the intrinsic cortical activity, and which causes perception of sounds, within the inner ear, within the skull, within the cavities, and things of that nature. So tinnitus The objective is an actual noise generated. Yeah, sorry about that. A little keynote action came in here. Get rid of that. So again, there's subjective, and then objective is an actual noise generated near the middle ear. And it's most often from blood vessels. Okay, and it could be increased or turbulent flow, as with atherosclerosis. It could also be abnormal vessels caused by tumors and vascular malformations. So differential diagnosis for subjective, you have acoustic trauma, may have a history of occupational or recreational exposure to loud noise. Of course, aging always comes up, barotrauma. Central nervous system tumors, which would be acoustic neuroma, and unilateral, often accompanied by hearing loss. It could be drugs, and we've mentioned salicylates before, loop diuretics as well, and it could be in the eustachian tube, some type of dysfunction going on in the eustachian tubes. You know, I know a lot of scuba divers and people that work in different altitudes, you know, in different atmospheres. They could also experience this in the inner ear, and you know there could be some trauma done to their inner ear as well by the pressure and you know by these atmospheres having an effect on these structures on the inner ear. Also, the history of URIs, upper respiratory infections, and it can be uni or bilateral. Also, history of infection. Meniere's disease, we'll have our own slides for that, but we have to differentially diagnose tinnitus from that. Also, episodic unilateral hearing loss with the tinnitus and vertigo that includes tinnitus and vertigo. And we need to do an MRI to rule out any type of acoustic neuroma if this is continuous and becomes problematic. Of course, this person's going to continue to complain. And also, any type of obstruction of the ear canal, impacted suramen. So suramen, what is suramen? That is just earwax, okay, a buildup of earwax. And also what we need to do, if you ever take a child's temperature using a tympanic sensor, you want to make sure that the ear is cleaned out because it could actually lower your temperature reading. But also can cause, again, if it's impacted, you know, a lot of the elderly get their ears cleaned out and they can hear a lot better. Some of them don't want to wear their hearing aids no longer. So, yeah, so suramen will cause, that impaction will cause this tinnitus and abrupted flow. And for the objective side, you want to take a look at and think about dural arteriovenous malformations, either unilateral or pulsatile. And you want to look out for myoclonus tensor tympani or stapedius in the inner ear, and also irregular clicking or unilateral type of clicking. There could be some turbulent flow in the carotid arteries or jugular veins that lead up to the inner ear, right? Lead up in and around. And also bruits or venous hum in the neck that can be actually heard with the use of the stethoscope. Now, the stethoscope could be used anywhere on the body. I mean, we could hear a lot of things. There's a lot of cavities in there. It's not unusual to put a stethoscope, you know, either the bell or the diaphragm, and put it right on the ear, right above the skull, right above the ear in the parietal area and the temporal area, right? To hear for, listen for bruits. And also, you want to differential diagnose the vascular middle ear tumor, which could be unilateral, constant, pulsatile, sometimes bruit on the, like I said, the auscultation of the ear. You pick up on an ear tumor, and very unusual. finding, but to say the least, I mean, you could use that stethoscope for a lot of reasons. And how do we evaluate it? We do a HPI, history of present illness. We ask them how long this has lasted, um, the laterality, the intermittentness, what's it look like? How long has this been going on? And we want to do previous medical history to include exposure to loud noises, TBIs, history of ear or central nervous system infections, and also drug use. The physical exam should include an ear exam, including otoscopic exam and bedside hearing test. Also, the physical exam should include a cranial nerve evaluation, and that run the person through a whole series of the tests, checking out the cranial nerves, and also auscultation of the carotid arteries and the jugular veins and around the ear itself with the stethoscope, right? Listening around there. So it's just a common thing with tinnitus. You got to check that out. All patients with significant tinnitus, right, should be referred for comprehensive audiologic evaluation by an audiologist, right? To get them in there and get them seen and get them taken care of. So very important. I think we'll talk about the inner ear in a little bit when we get into the parts of the ear. But there's a lot of things that go on in there. You have bones, you have the malleus and the middle ear and the stapes and all those things. They could have an effect on your tinnitus as well. So let's keep going here. So definitely a red flag is a bruit, particularly over the ear of the skull. And that's going to indicate some vascular changes going on in and around that area. And accompanying neurologic symptoms other than hearing loss. That's why you do the whole cranial nerve test. And it accompanying neurologic symptoms, right, and indicates possible tumor. With unilateral tinnitus, it indicates a possible tumor as well. How we treat it? We treat underlying disorders and correct the hearing loss, and we decrease caffeine. Not during my study sessions though. You need caffeine, right? I certainly need it. But for tinnitus, they say that it exacerbates the tinnitus. It raises your blood pressure a little bit and makes it, pop a little bit louder for these people. And the background sound can mask tinnitus as well. So there's a thing called tinnitus retraining therapy as well that folks have looked into. And the dizziness and vertigo portion, right, of this lecture, dizziness is often used to describe a variety of sensations, either faintness, which could be presyncope, lightheadedness, feeling of imbalance or unsteadiness, and a spinning sensation. Vertigo is a false sensation of movement of the self or the environment. So this could be your bed spins, right? For some reason, people, when they feel vertigo, they feel a rotary type of motion, a sensation of rotary movement. And it's interesting that it's only one direction. But a description, again, it's a description of a sensation, and it's not a diagnosis. And recall the vestibular system is the main neurologic system involved in balance. So you have the vestibular apparatus of the inner ear. You have your vestibulocochlear, which is your 8th cranial nerve, and your vestibular nuclei in the brainstem and cerebellum. You also have peripheral disorders that involve the inner ear and the cranial nerve involving the vestibular cochlear, and also central disorders involve the brainstem and the cerebellum, which is responsible for movement, right? So what do you think about that? Let's talk about this sensation of dizziness and vertigo. So, um, some people that experience a lot of heightened reactions and, different high speed and deceleration type of experiences can experience dizziness and vertigo because, they shake things up a lot in there, and they're thinking that it has something to do with, you know, um, actually making physical changes within that inner ear. So that could be a cause. And also, I'm going to send you guys an article about, because I think you guys would be interested in detecting bruits before we got in, with the actual tinnitus portion. I'm going to send you guys a study about bruits over the ear, where to actually, listen with stethoscope, and continue forward. So that's a picture. You have your anterior canal up top. You're looking at a good picture here of the anatomy. You have your cochlea, all right, and you have your saccule and your utricle right there, and you've got your posterior canal. It's kind of an alien-looking thing, isn't it? But this is your inner ear, and this is where things go wrong. This is where we could actually manipulate this and do some tweenaw. And there's some Western tests for this that we can help folks with. And we'll get into that here in a few slides. So the most common cause of vertigo is benign paroxysmal positional vertigo. Also Meniere's disease and vestibular neuronitis. You also have labyrinthitis. We'll go over these in depth. So when we evaluate it, we want to do a HPI and ask open-ended questions to better understand the sensations this person's having. And this will help distinguish the dizziness from the actual vertigo, and the severity, the episodicity, the frequency, and the triggers. The review of systems, you'll get your history of this person's upper respiratory history, his chest pain, his or her chest pain, palpitations, and dyspnea. The PMI is just a follow-through on what his chief complaint is. And so you're going to have history of head trauma. You'll be looking for migraine, diabetes, heart or lung disease, and drug use. All right, past medical history. And yeah, so we got your HPI, and you've got your review of systems, and you got your PMI, right? It's just all history, so you want to do a really good evaluation. Your physical exams should include vitals, and you actually check for fever. And let's see here. So again, your physical exam should include vitals, check for fever, any abnormal blood pressures. A regular pulse can indicate the primary cause of this dizziness and vertigo. You want to obtain an orthostatic blood pressure and do a head rotation while supine. I'll show you, there's a table for that, and I'll show you what that looks like. It looks like tweenaw, actually. And your nose and throat, you want to get a good evaluation of nystagmus. I have a good video of that, and also bedside hearing test. You want to obtain a gait assessment, cranial nerve assessment, to rule out central vertigo. So evaluating nystagmus includes peripheral nervous system disorders that have nystagmus latency of 3 to 10 seconds and fatigue rapidly. So there's either with fatigue or without fatigue, and it's usually inhibited by visual fixation. And I got a good video that demonstrates what that looks like on nystagmus. The central disorders have no latency and no fatigability. Nystagmus is defined by the direction of quick movements, and it's easier to actually see. Patient is lying supine with an unfocused gaze. Okay, and you want to slowly rotate the head to the left and then to the right laterally. And if no nystagmus is detected, you want to do a Dix-Hellpike maneuver, and I'll show you that as well. The patient is rapidly lowered from sitting to supine, and the head is supported 45 degrees below the horizontal, off the edge of the table, just like when we do Tweenaw when we're stretching out the scalenes and the SCMs, and rotated 45 degrees to the left. Return to the upright position, and process is repeated, turning the head to the right. And any position or maneuver that causes nystagmus should be repeated to determine fatigability. And so this is the test they do, the Dix-Hellpike maneuver.
In this positive Dix-Hellpike, notice that the patient initially has no symptoms,
dizzy.
and then after a few seconds,
I'm very
she
dizzy.
says she's getting dizzy.
Good.
This is called the latency.
Stay there. You're doing a good job.
Also notice that after 15 or so seconds, her nystagmus and vertigo improves.
Is it sort of gone away now?
Yeah.
In this slow motion video, you can clearly see that the nystagmus is vertical with upward beating eyes and a torsional component towards the downward, in this case, the left ear. In another positive Dix-Hellpike, again notice the initial asymptomatic,
Here we go.
and then she gets dizzy, and
Ooh,
again vertical
yeah.
nystagmus. More difficult to see the torsional component in this video, but it was there.
That's a pretty good one.
That was a long one.
In this patient with vestibular neuritis, notice how when he looks to the left, he has large magnitude nystagmus. When he looks to the right, it almost completely disappears, except for several small beats, which are occurring right now.
And I look back the other way.
And when he looks to the left again, they increase in size again. This is called Alexander's law, and this is a very typical finding in vestibular neuritis.
Look off to that.
In this second patient with vestibular neuritis, it's interesting to note that the first
look the other way.
examiner who looked for nystagmus did not see any because he asked the patient to fixate on his finger, which suppressed the nystagmus. Also note that there is a torsional component to this nystagmus. In other words, the upper poles of the eye are rotating a little bit towards the leftward ear. This is, again, very typical of vestibular neuritis.
Look over that way.
Again, note there is a torsional component to the nystagmus in vestibular neuritis.
Over here.
This
over
young
here.
man has nystagmus which
Right, look
changes
right over here.
direction
Right
depending
over my
on
finger here.
which
Yeah, good.
direction he's
Okay, now
looking.
look over
When he looks to the
here.
left,
Okay, look over here.
his nystagmus
Look right
fast
over here.
component is now towards
Good.
the
Okay.
left. This means he has a central cause for his nystagmus, in this case, ketamine.
Okay, pretty interesting videos and demonstrations of these tests and the types of nystagmus. The last one, pretty interesting with the ketamine. All right, let's get into some red flags for dizziness and vertigo. So for your Western medicine diagnosis class, where you're learning muscular testing and neurological testing and all that, I was supposed to teach that a few semesters ago to you guys, so that's why we're doing this now, right? So we'll get to that later. Just wanted to show you what's available out there and what's going on, what kind of tests that we can do to determine this nystagmus and this dizziness, vertigo, these kind of things. So for red flags, you want to always be cautious around the head or neck pain. And there could be a vertebral artery dissection or some type of hemorrhage going on in and around that area. You know, especially if you start to see, you know, differences in the equal amount of reaction to the absence or presence of light for the pupils. You always want to be cautious of that, of head injury, bleeding. Also, any type of uncoordinated movements called ataxia. You'll see, you know, stroke patients come in with, you know, right limb or left limb ataxia. But it could be as a result of cerebellar hemorrhage, you know, stroke, right? And loss of consciousness. You always want to be aware of that, of course. It's gonna be obvious. That's a red flag, and that is indicative of some type of central pathology and focal neurologic deficit, which is again central pathology, hemorrhage, or tumor involvement. So something severe, you know, you're going to be looking at continuous symptoms for greater than an hour, and this might be indicative of vertebral artery dissection we mentioned initially around the head and neck, hemorrhage, or hypoglycemia. And continuing with dizziness and vertigo, distinguishing the peripheral from central, as I mentioned a few of those terms on the previous slide. So peripheral is any ear symptoms, right? Anything away from the midline, right? Ear symptoms, proximal, severe, and episodic, no loss of consciousness. Okay, with central, you're dealing inside, so no ear symptoms. You're going to have gait balance disturbance as a result of central nervous system issues. Nystagmus, not inhibited by visual fixation. So that's the difference between peripheral and central. You always want to obtain their O2 sat with oximetry, and also to look out for any type of diabetic situation. You want to get a finger stick glucose, any type of sudden attack, and audiometry and nystagmography if hearing or vestibular function are abnormal. Yeah, and these tests, the electron nystagmography, if is a pretty unique piece of equipment. There's different pieces of equipment out there. Some of them look the same, but some of them look totally different. Some of them look more high tech than others, and I'll show you a couple of pictures of those as well. With acoustic neuroma, so you always want to think about Schwann cell derived tumor of the eighth cranial nerve. So what's a Schwann cell? So a Schwann cell is a peripheral nervous system cell, right, that is involved with the axonal lining of the axons, taking away from the central nervous system into the peripheral nervous system. So you're not going to find a Schwann cell in the CNS. You're always going to find a Schwann cell in the peripheral nervous system. So it involves and is derived tumor of the 8th cranial nerve. And it's an enlargement of the tumor that compresses the 7th and 8th cranial nerves and eventually the cerebellum, brainstem, and cranial nerve 5th and 9th through 12th. So you guys have already, last semester, we went over all the cranial nerves. So you guys should be very familiar with the cranial nerves. What are the signs and symptoms of acoustic neuroma? We have slowly progressive, unilateral, sensorineural hearing loss. But the onset can rarely be abrupt. You're going to have unilateral tinnitus, dizziness and vertigo, disequilibrium, and headache, and a sense of pressure or fullness in the ear. So acoustic neuroma, right? You're going to feel that. And a lot of symptoms. So you always got to look out for those neuromas, right? This is what it looks like. As you can see here, it looks like, I don't know if you guys can see that on, but I'm putting the mouse in and around the neuroma, and they're gonna feel that. They're gonna feel that pressure against this whole middle ear system here that is designed to help us with our equilibrium. And you have your tympanic membrane here as well. That could be affected as well in altitudes, things like that. And you have your labyrinth, right? So this pressure from this acoustic neuroma is definitely going to have an effect, and it comes with a lot of signs and symptoms. Diagnosis, we diagnose it through an audiogram and a positive result of asymmetric sensorineural hearing loss. They're going to have an enhanced MRI if the audiogram is positive to actually dig down deeper. And this gadolinium is a substance they put into the MRI to get better results. They can visualize things a lot better, especially the in and around the acoustic area. The treatment is observation and surgical removal if the symptoms are beyond the hearing loss portion. So this is what we talked about so far today. As you can see, tinnitus is a big deal, along with the dizziness and vertigo and the acoustic neuroma. These are all red flags, potentially things getting worse within and around the acoustic area and in the brain and in the skull. And what you need to remember about this is that the red flags are very important to know. And also, what's on a clinical note, that we're able to use that stethoscope for more than just chest sounds and listen to someone's lungs. We could actually use it on the skull and in around the ears. So think about that. And they'll probably look at you weird. You put that stethoscope on their ear, but hey, you're just listening, right? And you're checking them out. You're doing your inspection. So let's go ahead and take a 5-minute break. Okay, so far today we've discussed tinnitus and deafness. Not too much deafness. We'll get into that in the backup slides. But we talked about tinnitus and the seriousness of tinnitus. and the red flags involved. And we talked about dizziness and vertigo and acoustic neuroma. And the last part of the lecture, which is a lot, but the dizziness and vertigo covered the majority, actually, of this lecture. We have a few more subjects to cover, and that's benign paroxysmal positional vertigo, which is a disorder arising from a problem of the inner ear, right? And we'll get into that in depth. We're going to talk about Meniere's disease that came up a few times for differential diagnosis of tinnitus and other things. And then we're going to talk about labyrinthitis, inflammation of the labyrinth, and vestibular neuronitis. We're going to get into the middle ear and tympanic membrane disorders, mastoiditis, which is just a few slides. And then we're going to get into some otitis media, acute, and then the Q-tip injury of traumatic perforation of the tympanic membrane. Again, this is 2 weeks. We have a lot of disorders to cover next week as well. And the assignment will be on the backup slides involving some disorders secondary to a lot of these, or these could be actually secondary symptoms of more serious diseases. And diabetic neuropathy comes into play, diabetic effects of diabetes on the eyes as well. We'll get into that on the backup slides. So, benign paroxysmal positional vertigo, right? It's short, less than 60 seconds of episodes of vertigo that occur with certain head positions, and again, it's a disorder arising from a problem in the inner ear. So you need to know that. It's the inner ear. It's thought to be caused by displacement of otoconal crystals, these crystals that we all talk about, that are embedded in the saccule and the utricle. Okay, so I think I have a picture or two of those. And we talked about, what's important to know about this is that it's short, less than 60 seconds. And there's also nausea associated with this as well. And there's hair cells that are stimulated when the head is not moving, creating the illusion of motion, right? So these hair cells are moving, and your brain is picking up on this motion and thinking that you're moving. So it could be caused by spontaneous degeneration, otitis media, also previous ear surgeries, viral infection, and head trauma. So your TBI patients will get this. And this, understand this as well, this benign paroxysmal positional vertigo is one of the most common causes of vertigo. And it's a balance disorder, along with labyrinthitis and Meniere's disease that we'll talk about here in a few slides. You're looking at previous head injury with these, and also sometimes people never find a cause, because sometimes these people can't figure it out. It goes away and it comes back, and they're not really sure. They have no history of trauma. So we talked about this, these otoconal crystals, and there's tests to manipulate these crystals into certain areas, and some relief could be found by doing that. And also we talked about the otolith. If not, we'll get into that, or the saccule and utricle. We're going to talk about that too. And the diagnosis is typically made, like you saw the Dix-Hallpike test and the Sigamus. They could also, rule out this with the use of that Dix-Hallpike test. So, in typical cases, these medical imaging is not needed. They just do a few tests, and they can figure out what's going on. Signs and symptoms of benign paroxysmal positional vertigo. The vertigo is triggered when the patient's head moves. So the acute vertigo lasts a few seconds to minutes, and episodes peak early in the day and abate throughout the day. People do have nausea and vomiting with this. It's like the bed spins, and no hearing loss or tinnitus is involved with benign paroxysmal positional vertigo. So how do we diagnose it? Clinical evaluation, the Dix-Hallpike maneuver, it actually produces the nystagmus, and the gadolinium enhanced MRI, if findings suggest a central lesion, they put that in there so that it can enhance that MRI and find it right away. Uh, so this is what we talked about, those redistributed particles. I mean, if you can look here, the person starts in the seated position, and he's brought down to the table abruptly, and the head is rapidly turned even further to almost face the floor. And then the patient is returned to the upright position, and the head is rotated back to normal. And it's repeated. Yeah, this is what they call an Epley maneuver. And this helps alleviate some of the symptoms. It's not a diagnostic tool. It's more of a treatment aspect of this disorder. So this shake things around a little bit in there, right? So this is similar to tween eye. Now I stretch the scalenes like this, where we hold the patient's head off the side of the table, rotate their head 45 degrees. But as you can see, this is a skillful type of maneuver. And if you go this way in the clockwise direction, as you can see, the clinician will repeat this. The clinician rotates the patient's head towards the affected ear initially, then lowers the patient backward to the supine position with the head hanging over the table's edge. Okay. As we move down, going clockwise, the head is turned to the other side. And then as we come over, the head is turned further so that the ear is parallel to the floor. And like I said before, the head may be rapidly turned even further. Got to be careful. This person has some type of neck injury. But if he's okay, you can go ahead and try this. And the patient is returned to the upright position. The head is rotated back to normal. And this helps with the redistributed particles that they think is causing this, this condition. Meniere's disease. So we have an inner ear disorder, right? This inner ear disorder, it causes vertigo and fluctuating sensorineural hearing loss and tinnitus caused by pressure and volume changes of the labyrinth, the endolymph of the inner ear. So the risk factors include family history, pre-existing autoimmune disorders, trauma to the head, syphilis, and peak incidence 20 to 50 years old. And getting back to that Epley maneuver or repositioning maneuver, so it's used by pros, right? I mean, if you have proper training, you know, and been signed off, it's just okay to use, but be careful with it. So yeah, we use this to actually treat vertigo, right? And this benign paroxysmal positional vertigo. And we think it works by allowing the free floating particles, you know, from the affected semicircular canal to be relocated. So we're actually moving things around and using gravity, and therefore relieving the patient of this bothersome vertigo. It works. So to me, it just looks like Tweenot, you know. And we'll get on to the next, Meniere's disease. So again, Meniere's disease, as you know, you're going to have fluctuating hearing loss and tinnitus caused by pressure and volume changes. We mentioned risk factors, so that includes trauma and syphilis, and the peak incidence 20 to 50 years old. The sudden attacks, vertigo that last 1 to 6 hours and rarely up to 24 hours. You're going to have nausea and vomiting. You're going to have diaphoresis, so this person's going to be sweating, diarrhea, and gait unsteadiness. Tinnitus of the affected ear, constant or intermittent buzzing or roaring. May not be related to position or motion. You're going to have hearing impairment with Meniere and a sense of fullness or pressure in the affected ear. And this disease is progressive and hearing impairment gradually worsens and tinnitus may become constant. Differential diagnosis, vestibular migraine, viral, labyrinthitis, acoustic neuroma, and brainstem stroke. Wow. So, and how do we diagnose it? Usually clinical evaluation, primary diagnosis of exclusion initially, and during attack, the nystagmus, and falling to the affected side. The audiogram and MRI in patients with suggestive symptoms to rule out space-occupying lesions, so any type of brain tumor, right? How do we treat it? Antiemetics, prevent them from their nausea and vomiting, antihistamines, benzodiazepines, and diuretics and salt restriction. I guess salt exacerbates it. And vestibular ablation by drugs or surgery in severe cases. So we have our labyrinthitis. This is suppurative bacterial infection of the inner ear that can cause deafness and loss of vestibular function. That usually occurs with spread of bacteria to the inner ear during the course of severe acute otitis media. What symptoms are we going to have with that? Pain and fever. We're going to have severe vertigo in the nystagmus, and nausea and vomiting, tinnitus, and varying degrees of hearing loss. The diagnosis is based on clinical presentation, CT of temporal bone to identify erosion of otic capsule bone or other complications of severe acute otitis media, MRI if symptoms of meningitis or brain abscess is present, and the treatment with IV antibiotics is appropriate, again, for meningitis. So here you have your inflamed labyrinth and your inner ear and how it could have an effect. With all those symptoms, how do we differentially diagnose it? Because a lot of them are the same as the others. So you have to have a lot of experience and do a lot of homework and testing to get to the bottom line. Then we have our vestibular neuronitis, which is a self-limited episode of vertigo due to inflammation of the vestibular division of the 8th cranial nerve. Symptoms and signs: single attack of severe vertigo, nausea and vomiting, persistent fatigable nystagmus toward the affected site, which lasts 7 to 10 days. It's unidirectional, horizontal, and spontaneous. And there's no tinnitus or hearing loss with vestibular neuronitis. At least, it's not going to be in there. The person can have underlying tinnitus even before their vestibular neuronitis. So how do we diagnose it? It's going to be based on exclusion of the tumor, brainstem hemorrhage, or infarction. Audiology involvement, MRI for sure, and how do we treat it? Symptom relief with antiemetics, antihistamines, or benzodiazepines. And it usually subsides slowly over days to weeks. Acute otitis media could be either bacterial or viral infection of the middle ear. It's most common between 3 months and 3 years because of auditory tube structure. And there's an increased risk of households with a smoker and daycare attendance. Interesting, right? Always wondered about that inner ear stuff, and I heard that when I was a kid too. Like, stay away from smokers, you'll get an ear infection. So I guess it all is true, right? And the signs and symptoms, you're going to have ear pain, you're going to have hearing loss. Infants may be irritable and have difficulty sleeping, have fever, nausea, and vomiting, diarrhea in young children, and bulging. Erythematous TM with displacement of the light reflex and poor mobility. Serosanguinous or purulent otorrhea and severe headache, confusion, or focal neurologic signs may occur with intracranial spread of infection. So that's what it looks like. You guys have otoscopes in the clinic. You guys look into people's ears, question mark. Hit me back on chat, let me know. If not, I can give us a short class on that, send you a few videos. And this is also going to be an involved, excuse me, give me a second here. So we're going to teach you how to use all those diagnostic tools in your next class when we go back to campus. So how do we diagnose it? Clinical presentation. Unless fluid is collected during the myringotomy, cultures not generally done. The cultures are not generally done. And the treatment, 80% resolve spontaneously with analgesics, antibiotics in severe cases or recurrences. And the myringotomy, if TM is bulging and the pain is severe. Yeah, this laryngotomy is, I'm used to a different name for it, but anyway, all it is a surgical procedure when the tympanic membrane is sticking out and bulging and the pain is severe. They actually go in there and they put a tiny incision on the eardrum, on the tympanic membrane to relieve that pressure. So it's just a kind of a relief valve. They put a little incision and let it expand out to prevent and relieve actually a lot of that pressure, caused by all that excessive buildup of fluid to drain pus from the middle ear and so forth. They also, I don't know if you ever seen tubes inserted in children to keep it aerated for a prolonged period of time. And it also prevents reaccumulation of fluid. And some kids have these little tubes in them for a little bit, and also just because all those inner ear functions and, the anatomy is developing in there in young kids as well. So sometimes they have to take measures to have stuff drain out with the use of tubes. Let's get into mastoiditis, which is a bacterial infection of the mastoid air cells. And the greatest risk factor is concurrent or previous case of acute purulent otitis media. The signs and symptoms of mastoiditis are fever. You're going to have persistent throbbing, otalgia, concomitant acute otitis media, signs and symptoms, purulent otorrhea. Yeah, this looks like a pretty bad infection when it gets back there on the mastoid. I'll show you a picture of it here in a second. But it's going to begin days to weeks after onset of otitis media. The pinna is typically displaced laterally, so you're going to have, again, a buildup of fluid and inflammation, redness, swelling, tenderness, and fluctuation over the mastoid process. Now, it looks like I could stick needles in there, put little small cups and get everything out. We can't do that. Or lance it, right? But I'll show you a picture of it. It looks like this, right? Doesn't this look painful? Right in through here. Looks just painful. Yeah, they lance these things. And they, pull the pus out. Lots of antibiotics. How do we diagnose it? They clinically evaluated, of course. CT can confirm the diagnosis and show the extent And any middle ear drainage should be sent for culture and sensitivity. And they treat it with IV antibiotics, and of course they're going to drain it if present. Okay, here is the Q-tip injury, and the causes is insertion of objects into the ear. Don't put anything in your ears, don't belong there, right? And concussion caused by explosions or open-handed slap across the ear. If you get it just right, pressure, whack, right on the side, you can get that perforation of the tympanic membrane. Any type of head trauma that's severe enough, sudden negative pressure. Also, you're talking about scuba divers, right? And they ascend too fast or can't clear their ears down at those atmospheres. Barotrauma, right? And iatrogenic perforation during irrigation or foreign body removal. So, iatrogenic perforation. Wow, so caused by doctors. Yeah, imagine that. Okay, there's your Q-tip perforating the tympanic membrane all the way into the inner ear. And the symptoms are going to be sudden and severe pain, followed by bleeding from the ear, hearing loss, tinnitus. Well, I remember my little brother come running out of the bathroom, man. We were like watching TV. They were watching Walt Disney. He came out, he was like 4 years old, and had a Q-tip stuck in his ear. We had to go to Kaiser and Hayward, and they looked at us like, what the heck. So, yeah, it happens. So, diagnosis is otoscopy, and it's oftentimes it's evident with a Q-tip sticking in someone's ear. And the treatment, and we want to keep the ear dry. They give you some drops and stuff to put in there, some antibiotic drops and stuff, and some stuff to heal it up. Most close spontaneously, but surgery for perforations for sure. That persists greater than 2 months if signs and symptoms keep up. Okay, this is what we talked about today for the past hour or so. We talked about tinnitus. Remember, what you need to remember about tinnitus is that there's a lot of issues that could cause it, and we have to be on the lookout for all of these, right? We talked about acoustic neuroma and benign paroxysmal positional vertigo. You saw some cool videos of the nystagmus signs, and you saw some ability to treat some of the vertigo by moving some stuff around, what I call tweenaw. And you saw what Meniere's disease is. All of these are very similar, and they're very subtle changes in differential diagnosis. So it takes careful look. Some of them are obvious, but some of them are very difficult to differentiate. We talked about labyrinthitis, vestibular neuronitis, middle ear and tympanic membrane disorders. Those included mastoiditis, otitis media, and we also talked lastly about the traumatic perforation of the tympanic membrane. And next week, we're going to get into these disorders. We're going to talk about epistaxis, nasal congestion and rhinorrhea, stomatitis and thrush, sore throat, tonsillopharyngitis, peritonsillar abscess and cellulitis, epiglottitis, sinusitis and nasal polyps, and then laryngitis and laryngeal cancer. I also have some backup slides beyond next week that I wanted to include in the lecture, even though they're not on the syllabus per se, but a lot of them are going to be related to, like viral conjunctivitis, glaucoma. So you're going to see this. You may see this. I want to include this and give you guys an assignment on glaucoma, perhaps diabetic retinopathy. We're not going to do anything like that. And when we get into a diagnosis, we're going to be evaluating hearing loss. How do we do that with a tuning fork? So I may send you a video on that just to get you guys clinically minded when it comes to hearing loss. So let me go down to the, so when we start talking about diabetic retinopathy, you're going to see this, right? That's what it looks like. You can actually pick that up. And also, when we evaluate hearing loss, we're going to be using a tuning fork. And this tuning fork, there's a lot of categories. There's conductive, sensory neural, and mixed. And there's certain tests to actually differentiate the difference or both and those kind of things. So yeah, we'll get into that when we get together. But again, I'll probably give you an assignment on the, some of these disorders like glaucoma. I think we should mention that because it should be mentioned. And perhaps we'll cover cataract next week too. We'll just go ahead and cover it. And we'll cover diabetic retinopathy. All right. You guys have a outstanding week. I'll send this to you through YouTube and through Neo. You guys have an outstanding week. Yeah.